It's the premier anesthesiology event.
You have to come here. You must come here.
And it's happening right now. This is the Anesthesiology 2015 annual meeting. Hi, I'm Ed Highland, and this is ASA TV. From corner to corner, the San Diego Convention Center is teeming with educational and networking opportunities.
Oh, it's the greatest event of all time because not only do you get to talk to colleagues and you get to learn how practice improves, but you see the newest technologies and things that you can introduce in your own practices, and that's really important.
I'm looking forward to knowing more about the different subspecialties. I'm a CA2, so I'm really interested in learning more about cardiac and pain and things like that. So I'm interested to go to those types of meetings. And I'm also doing a presentation in a medically challenging case, so I'm excited to do that for the first time.
The people who don't come to these types of things, they tend to be surprised at the very last moment about what's happening to them and their patients. Being up to date, the patients expect you to have the most knowledge, and you can't find it anywhere else except for coming to the ASA.
In his presentation at the Lewis H. Wright Memorial Lecture, Dr. Kirk Hogan challenged attendees to make sure patients are aware of potential cognitive risks from anesthesia. He says while we can't predict POCD, in the specialty's ongoing effort to improve patient safety, more study using better technology is critical, especially in some patient subgroups.
In people over 60, at 3 months, there's a 10 to 15% chance, if not higher, of new onset deficits, and we really have to start looking at the people who might come to us with pre-existing deficits.
Attendees we spoke with agreed much more research needs to be done.
I have really been concerned that this should be part of our informed consent because I feel like we've been sweeping this under the rug.
They were just saying, if you're older than 50 years old, probably you don't want to have an anesthetic. I think that statement should be erased. We should be safer enough to be able to provide anesthesia without having any consequences.
A packed session for the usefulness, safety, and efficacy of ketamine. Dr. Daniel Carr focused on its current use at very low doses, not as an anesthetic agent, but to reduce or possibly even prevent pain.
The effects of ketamine are not permanent, they're transient, and one must find a way to supplement it with other agents or continue using agents like it that can be given orally to continue the beneficial effects. If you don't supply an ongoing continuation of the beneficial effects, they tend to wear off.
As a previously deployed and currently active Navy Reserve officer, we used ketamine a lot in Afghanistan while I was there treating battle casualties, and we saw its efficacy. And so I'd like to see its increased utilization here and more research to really perfect the correct dosing schedules and some protocols that could be utilized more readily.
For many, the road to successful participation in QCDR begins right here at Anesthesiology 2015. From enrollment to submitting data to the registry to understanding quality measures, attendees gained invaluable advice during these roundtable discussions.
You have to do it or you won't get paid. That's takeaway number one. So everybody has to figure out how to do individual physician PQRS, Physician Quality Reporting System, measure submission. You have to send data to the government on your performance. There are a variety of ways to do it. The favored one going forward will be through a registry. So yes, the government wants you to participate in a registry like NACOR. And the best way to meet your requirement for reporting will be through the registry.
A lot of issues with integrating quality measures into electronic health records and making it easier to report on. And the other thing that I've noticed is that a lot of groups having problems looking at compliance among individual performers. They're having difficulty getting data on that. So there's probably some things that we need to work on.
With so many market forces squeezing physicians and hospitals, both groups are recognizing that we cannot move forward in patient care unless we work together. The CMO for the American Hospital Association urged collaboration to transform healthcare. Dr. John Combs says we must move integration across silos, recognize more at-risk funding, and offer more public accountability. He argues this is the only way the specialty will be able to deal with the move from volume to value.
This has to do with payment policy from the federal government because they can't afford the system as it's currently designed. And they are going to force us all into this system. It will not go away. And when is this going to start? In 2019.
It was really nice to kind of get that sense of what the future has in store, how we're going to deal with it. Coming from a large healthcare system, I don't know how much of the little details apply to me, but it was kind of helpful for me in how I want to integrate myself in my health system and help kind of get us ready for that next step.
Some of us are perhaps a little bit behind the curve in understanding what's coming down the pike, but his lecture was very helpful in clarifying what's happening from a regulatory perspective.
While the perioperative surgical home is gaining traction as one option to value-based payment models, this session on pediatric PSH dove into the challenges when younger patients are involved. Panelists argue the pediatric PSH can work with careful planning and recognizing pediatric patients are usually diagnosed with very different conditions than adults.
Adults are doing joint replacement, they're doing procedure-based surgical homes, whereas in children we're doing more disease-based. We're looking at spinal fusion, tonsillectomies, VP shunts, bladder exstrophy, those kinds of cases at our pediatric patients. The reasons why they come back after surgery are very different than they are in adults. So again, we can't really look at preventing bounce backs after surgery. We have to look for our value added during the surgical episode of care.
Anesthesiology 2015 sponsored a clinical trials session, providing a high-profile large audience for initial presentation of major randomized clinical trial results. There were 3 presentations of original work with simultaneous publication and press releases. The studies included the safety of nitrous oxide on surgical patients with cardiovascular disease, the effects of a common steroid on chronic pain after heart surgery, and the safety of general anesthesia for infants.
It generates a lot of excitement. The public is interested as they read in their local media what's happening in the world of science as it affects their daily lives. We hear about drinking coffee, not drinking coffee, what will cause cancer, won't cause cancer. These things are typically the large trials that are likely to be important in how people are treated and how they seek and get medical care, come from these large trials. In the anesthesia world, we've never done this before.
It's a great opportunity that's been provided by the American Society of Anesthesiologists and also by the journal Anesthesiology, and we were thrilled that our paper was accepted to be part of this session.
We have reached the halfway point in this 5-day Everything in Anesthesiology event. Many celebrated by participating in the first ever charitable networking event, an international tasting. Let's take a look back at that special event. For now, I'm Ed Highland, ASA TV.